Well, I want to thank you for inviting me to speak with you all today. The medical home, of course, has been around for a long time, ever since the American Academy of Pediatrics came up with the concept in 1967. And through the years, we've seen how it's become really the dominant model, the best model for providing the medical care for children. It's proved itself in everyday situations for all aspects of their care and being able to coordinate those aspects. What's come into light recently, though, has been the fact that those same elements for everyday care also lend itself to ensuring the health of children during disaster situations. And unfortunately, it's something that we haven't really utilized to the maximum until very recently. So what I would like to do today is to talk about basically not only why the medical home is important for the health of children in disaster, but even more importantly, the how we can make it happen and utilize that potential there. Just first, I have nothing to disclose. And what I'd like to do to start off is to kind of talk about my own experiences and how I became involved in disasters and children. And my experiences started around Hurricane Katrina on August 29, 2005. And at the time, I had a solo private pediatric practice in the town of Bay St. Louis, Mississippi. My home was in the neighboring town of Waveland, which, for those of you who aren't familiar with where that is, it's right about here. In other words, pretty much at the center, at the eye of the storm when it finally came ashore on the Mississippi Gulf Coast. And so fortunately, my family and I, we were able to evacuate ahead of time, and we traveled through Montgomery, Alabama, eventually making our way to our family up in Maryland. And kind of like everyone else around the country, we were stuck watching this situation play out on TV, wondering what was going on back home. Anderson Cooper, for instance, was there in Bay St. Louis. FEMA was not. But anyway, we're watching the footage, and our first concerns are about our friends, about my coworkers, about the hospital. Well, as it turned out, at the community hospital, this is what was taking place. This is footage from the security camera as recorded when the waters came into the emergency room here. And this was an area that back in 1969 had been hit by Hurricane Camille, which at that time was a Category 5. So everyone thought this was the most severe that nature could throw at people. What they hadn't counted on, of course, was a storm the size of Katrina. And so while the winds were not as strong, they were plenty strong. They weren't as strong as when Camille came through. It was the storm surge and the flooding that truly made a difference and unfortunately accounted for most of the devastation around the town. This was a picture that someone took as the floodwaters started to rise behind the hospital. And you can see this SUV is about to be submerged. And that white and brown building in the background, that's where the hospital generators were. So before long, they were, of course, knocked out of commission, and people had to really fend for themselves in a fairly dire situation. So about a week and a half after the storm, tried to find out more, ended up taking first trip into town, and there was just mass devastation everywhere that you went. They later determined that in the town of Waveland, which again was where my home was, about 90% of the buildings were either destroyed or damaged or basically rendered uninhabitable for the time being there. So went back, took a trip, looked around the house first of all, and this is the situation that we found there. The water had risen up about 3.5 feet inside the house, even though the house was already elevated 4 feet off the ground. So again, the storm surge in some places was as high as 30 feet, which is pretty unimaginable. Looked around, realized that we had lost almost everything in the house. There was this stench of mold wherever you went inside any sort of building, and the trees were down. Everything was really destroyed around town. Next stop was to the office to see how that had fared. And again, it was a similar situation there, unfortunately. Again, the water had come up about the same amount, 3.5 feet or so. And this file cabinet here, which you can see, we couldn't even get it open because the paper files inside had swollen from all of the water there. However, the fortunate thing was, when I had started my practice about 1.5 years before this, we had used the electronic medical record. And this proved to be a lifesaver not only for the practice, but more importantly for the patients who had scattered and evacuated all over the country. So for instance, I would be fielding calls while I was in Alabama from a patient who had evacuated to Philadelphia, and they would call me up and say, you know, I'm trying to enroll my son in the public schools. Is there any way you have the medical records? Is there any way you have the shot records? And I would say, actually, I do. Let me print it out. Let me fax it to you. And again, this proved to be a lifeline all around there. So one of the important lessons that came out of that. Well, again, the housing was all destroyed around town, as well as the office space, of course, too. So for the first few months after the storm, there was no office space to be had at all. The hospital had some space available, relatively undamaged, in a town called Diamond Head, a few miles north of the coast. And they said, you can use this for the time being. Unfortunately, I had to share it with the other doctors in town who were in a similar situation, which meant that I could use this space 2 half-days a week. But it was enough to start seeing patients and establish some sense of normalcy for myself and for them. We gave the first vaccines in the county during that time, because keep in mind, the health department had also been damaged and was out of commission. And then finally, around December, the hospital had procured a classroom space, set it up in the parking lot of the hospital there, and we turned that into a full-fledged pediatric office for the next 6 months, complete with 3 exam rooms, storage space, lab, vaccine storage, and we had a makeshift waiting room / business office. We didn't have a bathroom. When we had to, for instance, get a urine sample from patients, we would have them go out to the parking lot to the porta potties and then bring it back. It wasn't an ideal situation, but we made it work because we really didn't have to. Anyway, about a year after the storm, moved into a real office, and then for various reasons, personal, professional, financial, thinking about the future and my own family, decided to move to the Florida Gulf Coast, which was where I've been since. And fortunately, knock on wood, have not experienced a hurricane in that location, at least not yet. So I bring up this story not because I think that it's necessarily anything that's exceptional or particularly dramatic in its own way. I mean, I think if you talk to any number of people, physicians or otherwise, on the Gulf Coast, they can tell you stories that were even more harrowing and about the way they lost even more things than I did. I mean, I was relatively fortunate through this experience. However, I use it just to illustrate the fact that, first of all, these disasters can always end up surprising us. Again, this is an area that had gone through Camille, and yet Katrina was something truly unexpected. And the fact that wherever we are potentially prone to having these things come through. And in the last few years, of course, we've seen this around the country. We've seen the events of 9/11, we've seen the earthquake that happened down in Haiti, we've seen Japan and the earthquake and the tsunami and the Fukushima nuclear disaster, the earthquakes that have gone through the Midwest, such as Joplin, and then, of course, particularly relevant to you is Sandy, which had gone through last year, of course. Again, all of these things, you know, the East Coast is known to be at risk for hurricanes, but when Sandy came through, it was something that was of a magnitude that no one had quite prepared for to that extent there. And then we've also had some things which have truly come out of the blue, such as the H1N1 pandemic, the Deepwater Horizon oil spill in the Gulf, and then the predecessor to Sandy, which was Hurricane Irene, which ended up striking, of all places, Vermont. I mean, if you had asked people up in Vermont if they thought they were at risk for an event like that, obviously they would have said no until it happened to them as well. So, of course, we've had these number of events. They keep coming through. Some of them are expected, some are unexpected, but I think the point is we really have to be prepared for just about anything that comes our way. And we're talking not just about, of course, the natural disasters, but there are also man-made events. And I say man-made because that includes both the purposeful events, such as terrorist incidents, but also accidental things. So we can come up with this list of disasters, but what I find more helpful is if we can come up with a definition, and the one I like to use for that comes from the federal government, from the Stafford Act, which is the legislation that outlines the federal government's response to disasters. And within that, they define a disaster as a catastrophic event that overwhelms the local capacity to respond. And the reason I like this definition is because of the phrase local capacity. Because what that means, what that implies, is the more robust that local capacity is, the more you can handle on the local level, and the less likely you are to get overwhelmed and have to call in the outside authorities and rely on their resources, which is when things start to break down and bad things start happening. It also means that the more you can be prepared on an everyday basis, the more you can be prepared when it's actual game day. And the Boston Marathon that happened earlier this year, I think, is an excellent illustration of this point. Of course, everyone knows Boston is a world-class medical city. I mean, they have however many pediatric hospitals, they have trauma centers, they have just an enormous amount of medical experience and expertise. But what really made the difference on that day was the fact that the hospitals and the people and the city as a whole had run drills and exercises and had prepared for something exactly like what had taken place there. So when the calls came through that there were bomb blasts going off at the finish line of the marathon, people jumped into action, they knew exactly what to do, and everything started falling into place. So as a result, in the hospitals, they cleared out the emergency room bays, and they had teams on the standby ready to receive the patients. They did the same thing in the operating rooms, and they cleared out them. They had surgical teams on the ready, they had neurosurgical teams, they had burn teams. Everyone was in place. They evacuated patients from the scene and had them up in the operating room within 30 minutes. And as a result of all this coordination and these incredible efforts, no one, other than the first 3 unfortunate casualties, no one else lost their lives on that day. There were reports from some of these first responders that patients basically got into the operating rooms and had minutes to spare before they might have bled out and died. So you can see not only that these efforts that we make on a local level, they are possible. I mean, Boston proved that. But more importantly, they actually make a difference and can save lives. So of course, all of you here, most of you are not working in trauma centers. You're not in emergency rooms. You're in office-based settings. So you may be asking, well, why does this apply? The answer is because as pediatricians, even in the primary care setting, we're going to see kids. We're on the front lines of seeing kids. And it may not necessarily be trauma care, but we're going to see kids who might be exposed to certain infectious agents. They might have gone through a hurricane or a disaster and they've evacuated or moved to another area. Or they might not have been anywhere near the vicinity, but they've seen it on TV and they're being emotionally affected. So we have an important role to play in helping children and families through this sort of crisis. And it's important to realize that, when we talk about this, this very much is a pediatric issue. People say, well, this affects everyone. Why does it matter for kids? Well, the reason is, first of all, because children are going to be affected in almost every disaster that we come across there. And so even the ones that, we would think might have minimal effect on kids. 9/11, this happened downtown Manhattan. But what most people don't realize is that on that day, there were 7 schools that were open and had the kids there in the immediate vicinity of the Twin Towers. So there were nearly 6,000 children that were directly affected when the planes hit the Twin Towers. They had to get reunited with their families. They were potentially exposed to all of the dust and debris, the same as the adults. And even more importantly, where were they going to go to school for the next few months now that their classrooms were unable to be occupied? And then a month later, the anthrax attacks happened. And again, this didn't seem like this would be a pediatric event in any sort of way, but yet one of the victims was a 7-month-old child who the experts believe had been brought to the mother's place of work and had been exposed to the white powder at that point there. We've seen this again in Boston. Just to bring that up, again, when the marathon happened, the schools were off. It was a holiday. So there were children there at the event and were affected. One of the fatalities, unfortunately, was a child. And then 2 days after the marathon was the fertilizer plant explosion in West Texas, where the middle school of the town was practically next door to the fertilizer plant there. And then a month later was Moore, Oklahoma, when the tornadoes came through, and the schools were directly hit by that as well. So you're going to find in every disaster, pretty much, kids are going to be affected. But beyond that, you may have some situations where kids are disproportionately affected, whether it was a situation that happened in Haiti When the orthopedic surgeons came down, of course they were prepared for all of the trauma from the earthquake. What they didn't realize was that Haiti has a very young population relative to the U.S. So they were really unprepared as far as having the right equipment that was sized for the pediatric patients there. We've also unfortunately seen natural events such as the H1 pandemic. Again, particularly struck children, really surprised everyone when you compare it to the seasonal flu, which of course has a very high incidence among the elderly. And you can see through these graphs that really the ages 5 to 19 were the peak incidence for this disease here. And then we've also had some occasions where people have purposefully sought to target children to provoke anxiety and fear and terror through society. Timothy McVeigh, when he planted the explosives under the Murrow building in Oklahoma City, purposefully put those under the daycare center in order to cause as much of what he called collateral damage. There was the school siege in Beslan, Russia a few years ago, the shootings on the youth camp in Norway, and then of course most recently Sandy Hook Elementary in Newtown, Connecticut. So aside from the fact that we know children are going to be affected, and sometimes disproportionately, the question is, well, does that matter? Does that affect how we're going to respond to these things? And of course, for all of you, you realize that children are not just small adults. The children have very unique needs that have to be addressed in a very unique manner. So by way of illustration, I'm going to talk about just a few of the past disasters and how this has played out, starting with 9/11, where one of the things that we learned from that day was about the media exposure and the importance, the way that can shape the children's response and their mental health afterwards. So all of us were, of course, watching the footage on TV, on CNN, and we're seeing the replay of the planes going into the Twin Towers. Well, when this was happening, there were some young children who didn't quite have the context for this, so they're seeing it happen again and again, and they're thinking that this is real. This is not a replay. This is actually happening time and again around the whole country. And you can imagine not only the amount of fear and anxiety that's going to provoke, but also the feeling that this might be happening in their own hometown. So we learned very quickly after 9/11, for instance, that we have to limit the media exposure that children have during a disaster, and we have to be there to walk them through it and explain what's happening. Similarly, after Katrina, switching gears to the most basic needs such as feeding and nutrition. And what we had seen, this was an article published in Pediatrics by my colleague in Biloxi, Mississippi, Mitch Gruich. And one of the things he was doing during those first few days, in addition to, of course, providing medical care, was he ended up going around town and delivering formula to parents who hadn't prepared, and even to the shelters that hadn't prepared for these basic needs of children. You can't just give a toddler one of these MRE packets and expect that it's going to be good nutrition for them. And similarly, speaking of the shelters, a lot of these places had not considered, were these good places for kids to be, even on a temporary basis? You can imagine inside the New Orleans Superdome, if you're there with your family, you're going to be wondering, who's the person in the cot next to me? Is there a place where I can let my child run around and play for a little bit? If you're a breastfeeding mother, is there a space where you can nurse your child and feel secure? These things really hadn't been considered up until this point. For the families that unfortunately were separated, it took 6 months after Katrina for the last families to be reunited and brought whole again. And this is a situation that we're still dealing with today. You again talk to some of the responders in the hospitals in Boston, and they said this was one of the premier issues that they still had to deal with and was causing problems. So we're not there, but it's an important thing that has to be considered. We also saw for the families that then had left the shelters and were moving back into housing, a lot of these families after Katrina, of course, were set up in trailer parks, and the trailer parks, again, had their own disadvantages. Again, they might not have been safe spaces. They might not have had places where kids could run around and be secure. And inside the trailers themselves, again, cramped environment, cluttered, a lot of people sharing a very tight space. And what we found was that the children weren't able to explore and toddle around the environment. So as a result, they were actually having developmental delays while they were in these places here. Out in the community, you have to make sure that, of course, there are places where kids can do their thing, which is run around and play and be in school and learn. So you have to think about the threats to the physical environment. You have to think about the schools and the child care centers and the libraries and the other places that children go. Again, unique to kids. These aren't going to be considerations that you need for adults necessarily. And it's worth mentioning as well that the medical needs are going to be different. So for instance, during the first year or two of life, children need to see the doctor many times, not only for, of course, the immunizations, but also just for the regular checkups to make sure they're growing and developing well. Again, not a consideration for the adults, but an important thing that we have to provide for children. Now, a few years ago, the National Commission on Children Disasters was convened, and they found these things, they collated the findings, they published them in a 2010 report to the President and to Congress, and they also laid out a roadmap from the federal level as to how the goals and the unique needs of children could be met. And it's a very important document. I encourage you all to go online and read it. But the document, again, was really targeted towards the highest levels of government there. So it really falls more to us to implement it at the state and the local level. And for the rest of the time, I'd like to talk about how we can make that happen, how we, as pediatricians and those of us involved with the medical home, can promote the preparedness and resiliency in the families and in our communities. And what I'd like to do for this is to break it down into 3 levels. First, the individual level, where we interact one-on-one with patients. And then second, the things we can do as a practice as a whole to be able to preserve continuity of care. And then finally, interfacing with the other people out in the community and the things that they're already doing, or perhaps the things that we can get together. So first, on an individual level, it's important to realize that as pediatricians, parents are going to come to us, which means we have a responsibility to be ready when they do. Parents look to us for medical advice. They look to us to interpret what they see in the media. There was a study done a few years ago, a survey done by Irwin Redletter and colleagues in Columbia, and what they found was that people want to hear more from their pediatricians than from any other source, more than the CDC, more than the federal government, more than the state and local authorities. They want to hear from us what to do and what things mean. And furthermore, what we tell them actually does make a difference. People act on it as well. And there was a similar study about 3 years ago, which found that looking at folks who their primary care doctor had talked to them about preparedness versus those who had not talked to them about it, the folks where their doctor had encouraged them to be prepared for a disaster were 3 times more likely to actually go out and have a disaster kit for emergencies there. So what we tell parents is important, and it really does make a difference for their preparedness. So what is it that we should be telling them? Well, fortunately, we don't have to make this up from scratch. There are a number of great resources out there. FEMA, ready.gov is one site. The American Red Cross has an excellent preparedness website. And all of these resources, if you go to them, they're pretty much going to say the same thing. Have a kit, have a plan, and be informed. So it's really that easy. However, you know, we're all pressed for time. I'm a primary care pediatrician, just like many of you. I'm in the office 5 days a week. You know, we've got 15, 20 minutes allocated for a checkup. There's only so many hours in the day to kind of get the message out. So I would argue that in that setting of limited resources, and particularly building on the strengths of the medical home, it might be worthwhile to focus particularly on the children with special health care needs, which of course is one aspect where the medical home has really shined in terms of coordinating the complexity of care. These are the children, of course, who are more vulnerable in everyday situations. They have particular needs. They're vulnerable to certain things in the environment. Well, you can imagine in a disaster situation, these things aren't going to get any better. They're going to be even more vulnerable and even worse off. This was a study done that was published in 2009 looking at the Texas Children's Hospital Diabetes Clinic. And they asked the parents and the patients, they said, you know, are you prepared to handle your diabetes in an emergency? And most of the patients they talked to said, yeah, I think I can do this. I think we're ready for it. But then when they talked more about specific disaster preparedness, the numbers started falling off dramatically. And you can imagine that if someone is not really prepared to handle the disaster, that in turn is going to play out in terms of how well they can manage the diabetes, and it's going to affect their blood sugar, if nothing else, just from, for instance, the stress driving the numbers up there. So again, consider focusing on the children with special health care needs if we're in an opportunity of limited time. Now, of course, there's not just the physical health, but there's also the mental health. And this is overlooked a little bit, but it's important to remember that in the day-to-day situation, first of all, we're already doing this. We, as pediatricians, primary care pediatricians, are really the de facto mental health system in this country. We are where parents first and foremost come for advice, for guidance on different behavioral and mental health issues. And so what do we do on an everyday basis? We counsel them, we offer the advice that we can. If it's beyond our scope, our expertise, we try and refer out to other professionals. So in the event of a disaster, you're going to see this same thing happen, and we have seen it happen. We've seen it in Joplin, we've seen it with really every disaster that's come forth, whether it's that the parents know what they're dealing with or they just understand that their child is upset and is acting out, and they are going to come to us for help. So what do we do when they come to us? Well, first of all is let them know what is expected in a situation like this. Let them know the way kids typically react. And David Schoenfeld is going to talk a little bit later today in much more detail about this. But even more importantly, not only what they're seeing, but what they can do about it. We can give them some concrete, simple steps to help them help their child cope and get through this situation and be resilient there. All right, now switching tracks just a little bit. In order to provide these services, to provide the physical health and the mental health services for children, we have to make sure that our practices are ready as well. And we know, just like families and children with special health care needs are not prepared for disaster, we know that medical practices aren't either. This was a survey done in 2007, and they found that primary care physicians were less prepared for disaster as compared to any other health professional, whether it was a nurse, an administrator, so on and so forth. The Medical Group Management Association produced a study a couple years later, and what they had found was that even though the vast majority of the practices they had surveyed anticipated they would probably be going through a disaster in the next 5 years, only 2/3 of them had a plan in place. And when you talk to them about what steps they had done with that plan, such as had they conducted drills, had they talked to other agencies and coordinated, those numbers started dropping off dramatically there. And of course, just like we talked about with families, having a disaster plan is more than just having the right stuff on hand. So this is a picture of the generator that's outside my office. And by way of disclosure, I'm an employed physician. I didn't have anything to do with this. But if any of you have ever been to Southwest Florida, you know that it's a pretty flat area. So you can imagine that with a generator just a little bit off the ground, it wouldn't take much of a flood or a storm surge to knock it out of commission. And then you'd have to scramble and come up with your alternative plans. And this is the situation that happened, for instance, during Sandy at NYU Langone Medical Center, where the generators, fortunately, were up top, but the fuel pumps were down in the basement. So when the storm surge came through, the generators ended up being knocked out of commission, causing a lot of stress. Fortunately, no one suffered any casualties as a result of that, but it really made a harrowing situation for the staff and for the patients during that evacuation subsequently. So again, it's more than having just the right stuff. You have to have the plan, or if you even want to take it in terms of what Dwight D. Eisenhower had once said, plans are nothing, planning is everything. And the buzzword in the business community at this time for planning is what they call continuity of operations, which is just like it sounds. In other words, how are you going to preserve those operations in time of crisis, which for the pediatric medical home consists of largely, one, how are you going to see the patients? How are you actually going to provide the care? And two, just as important, is how are you going to keep the financial cash flow? How are you going to collect and pay the bills and keep those doors opening so that you can continue to provide that care in the first place? So there are a number of considerations that you have to think of ahead of time and learn to be flexible. You have to anticipate if your office is damaged, where are you going to go? Where are you going to be able to see the patients? If your EMR system is down and you can't have access to the internet, How are you going to be able to maintain your records or perhaps function without having any access to them in the first place? Are there going to be certain services that you're going to have to cut back or change or postpone, or similarly, such as when I was in the trailer and we didn't have a working bathroom, we had to work around things there. And of course, keeping in mind that you may be, again, like my colleague Mitch Gruich, providing more than just medical care. You may be attending to other needs of the community because you are the pediatric experts and advocates there. So in addition, though, we have a lot to consider in our professional roles, and as my son Ben would illustrate, you have to juggle your different obligations. Of course, we have our obligation to the patients we see in the office, but perhaps also to the local hospital and our ties to them. We have to think about our own families and ourselves, and also our obligations and responsibilities to the greater community. And sometimes these needs are going to pull us in different directions, so it's important to think about these at least beforehand, or at least be aware of the potential conflicts and the decisions that you might have to make there. You're going to hear a little bit later about the importance of communications. And of course, again, we talked about the fact that parents are going to come to us in the event of a crisis, so we have to be ready. Pediatricians and the medical homes are really communication hubs for the community. If you look at this diagram here with all the arrows, there are more arrows going to and from that little box saying pediatricians than to any other source. In other words, we really filter and process communications to and from everyone else in society, and we have to be ready to fulfill that role, particularly if the traditional communication lines have fallen through or are getting overloaded or similar. Another unique pediatric concern, which you're also going to hear about in a little bit from Meg Fisher, is about the vaccines. Again, you have to be able to make sure that the vaccines are viable, that they're kept cold in the proper storage, not only to provide, of course, the proper care for children and make sure they're being kept healthy, but also because most pediatric practices have a tremendous amount of financial capital tied up in this. So if you lose those vaccines and you don't have the proper backups and you don't have the proper insurance, it's going to be a financial hit that might be unrecoverable, and then your practice goes under and you're not helping anyone there. Speaking of vaccines, I want to take a step back to H1N1, and of course, because one of the important roles that the medical home played during that was getting the limited supply of vaccine out to the highest priority populations, such as the children with special health care needs. And so as a result, our services evolved more than just from the patients in our unique population, but we ended up being a partner and an arm of the healthcare delivery system as a whole. In other words, without us, we're not sure how many of these children would have gotten those vaccines and been protected from the virus in the first place there. And of course, we also saw this play out in terms of surge capacity and surge planning. So for instance, the more that we in the medical home could handle in terms of telephone or getting children into our offices to evaluate them there, the more it eased up the strain on the emergency rooms and the inpatient facilities and so on and so forth. So there was a tremendous downstream effect that for the first time we started to realize and to capitalize on. And taking this to the next step, of course, we're starting to utilize this to a greater extent in terms of the overall public health care system. The medical home and the pediatric office has long been associated with this, but in a very limited way. So for instance, we see a child who has chickenpox or pertussis coming into our office, and we have to know how to navigate the system and make the report. Well, in the event of a disaster, this becomes even more important, again, because we're on the front lines. This is where children may present, not just to the emergency room, but if they have, for instance, a funny cough or a funny disease, they may be coming to our office. So we have to have that connection to the public health, know how to work the system, and they in turn look to us to be the surveillance arm out in the community. So for instance, if you have a child that comes into your office, such as my son Elliot here, and he's got some spots on his face, you want to know what to do in that sort of situation. Is what you're seeing a potential threat to the community? If so, how do you deal with it and how do you coordinate to the folks in public health? And then in turn, you have to think about the downstream effects, such as when parents hear about this and they call up the office and they want to get in and be seen, and how are you going to handle that on the practice basis? So again, thinking back to H1N1, where things worked right and they worked well, a lot of times it came about when the practices and the pediatricians had good communications already in place with their local public health authorities there. They had the mutual communication and understanding. Each of them knew who the other was. And so on a community level, we found that as simple as it is, in the words of the website of Los Angeles County, being prepared for an emergency begins with hello. It may sound that simple, but it really is a tremendous tool that's been underutilized, just simply making the connections here. It's been said that in a disaster, it's not the time to start handing out business cards. In other words, you want to have those relationships established beforehand with the other folks in the community who are also seeking the same ideal, which is, of course, the health and well-being of children, which means before the event strikes, get out there and just start making the connections and talking to folks and finding out what's going on. What role are they playing? How can you contribute to what they're doing? And making sure that they have considered the needs of children in disasters. The American Academy of Pediatrics, in conjunction with the CDC, just last year published a Pediatric Preparedness Resource Kit, which lays out a lot of the steps and suggestions in terms of how to make this happen on the state and the local levels. So I'd encourage you to go to this and come up with ideas and see what's already in place at other areas around the country. And at the end of the day, today, Esther Chernak and Ali Horowitz are going to talk much more also about the groundbreaking Philadelphia Community Preparedness Project and their findings and their suggestions. You're also going to hear a little bit about what happened in Joplin after the tornadoes there. Well, you had the folks in the community who realized that the children's mental health needs, that the professionals seeing these kids needed assistance. They needed more information on how to address these needs, how to coordinate and come together. So what happened was a very innovative conference where they brought together basically all the folks involved in meeting those children's mental health needs. They brought the schools, the mental health professionals, the pediatricians together to talk about it and figure out ways forward. So again, Renee White, we're lucky enough to have at this conference, and she's going to talk more about that as well. So as we look to the future, of course, what else do we want to see happen? Well, aside from these community-based partnerships where people come together to bring all the resources to bear on this, we want to utilize the medical records. Of course, everyone is now going to electronic records. We've seen the rise of the meaningful use requirements, and more importantly, if we can utilize that to facilitate bilateral instantaneous communications, there's great potential there that has to be tapped. So for instance, if you see that kid in your office who might have a case of chickenpox, imagine if your electronic medical system could prompt you to make an automatic report, and it would automatically collect the data from the medical record of that visit and send it on its way. Similarly, what if it could easily draw down information from the health department, whether it was the immunization records or just something about a public health issue that's going on right now, and import that into the record to give you real-time guidance. That's the future that we'd like to see happening. And of course, there are a number of folks here in the Pennsylvania chapter who are working very hard to make that happen, who are really at the forefront of this. Because at the end of the day, there's only so much time and only so many resources to go around. So, of course, we all hear that we have to do better with less. Well, if we can incorporate the tricks and the collaborations together into the medical home to make that happen, then I think we're really going to be at a tremendous advantage. From the national level, I just want to say that the American Academy of Pediatrics is also working on this. We've made disaster preparedness for children a priority of the organization, and we're trying to make sure, first of all, that all the emergency planners know about these unique needs of children, that they're being considered in planning, that they're being considered in research, and their needs are being met. We want to see these things carried out on the state and local and regional levels, as you've seen. We're also trying to implement this into education, not only the professional education for the doctors already in practice, but also in terms of medical school and residency and fellowship. And the AAP is also committed towards taking the recommendations of the National Commission on Children's Disasters and being one of the foremost agencies to make sure that they get carried through and implemented and put into action through all phases of disaster response and recovery as well, and working with the other partners that are out there, such as Save the Children and other groups. I would encourage you to also go to the AAP's website, aap.org/disasters, which has really up till now become the national de facto clearinghouse on this subject there. And you can find all sorts of resources for everyone, for parents and children, for professionals, for doctors. You're going to find it there to help you through it. So ultimately, what is it that we want to see accomplished? We talk about improving the health of children, but what is that going to look like? Well, it's everything that I've thrown up on this slide here, which is an awful lot to deal with. But the reality is that these are the things that have to be considered whether we like it or not. The good news is that, first of all, you all in the pediatric medical home, out in your communities, out in your practices, are not alone in this. Again, you have a number of other community partners that are working to make this happen too, and we just have to tap together and work together. You have the AAP, you have the state chapters. The Pennsylvania chapter has really been at the forefront of these efforts, for instance. You're not alone in this, and you don't have to be. There are any number of resources and partners available, and even more importantly, I think we've already made tremendous progress in the past many years. If you look at what happened after 9/11, and you looked at the mental health responses and the things that we've learned since then and implemented, and then you look at Katrina and the mistakes that were made, and then you compare that to the experiences around Sandy and around Newtown, Connecticut, for instance. Newtown, after that event happened, after the shooting, the messages about the mental health needs of children and how parents could address it were all over the media, thanks in part to the AAP and the other organizations that are working towards this. So we've made tremendous progress. There's still a lot to be done, but the good news is that it's getting brighter, and we are making a difference for the health care of children in this country, in every day as well as in disaster. And so in closing, I just want to give you this quote from Winston Chu, the chairman of the Singapore Red Cross. And what he said, I like this: "We cannot prevent disasters, but what we hope to do is to be more proactive, to be better prepared so that we can react better and faster." And my hope is at the end of today's conference that you all are inspired and engaged to figure out some ways to make this all happen in your own practice and your own community to ensure the health of children in disasters. And with that, I thank you very much, and I hope you have a great day today.